guys, so I'm Shamila from Miller Med Talk. So I'm going to start with, first of all, one of my favorite topics, which is diabetes. So what is diabetes? So usually when we ingest carbohydrates or have a carbohydrate-rich meal, the food molecules go down into the digestive tract, into the small intestines, and gets broken down into sugar molecules and glucose. And then what happens is our blood will have a lot of circulating blood glucose, and the beta cells located in our pancreas will secrete insulin. Insulin is a hormone that will take up the blood glucose from the circulatory system and take the glucose into the cells, which we then use as the fuel, so energy. What happens in diabetes is there's two forms. So type 1 diabetes. Okay, so type 1 diabetes is when the pancreas does not produce insulin. It's caused by autoimmune B cell destruction. Due to this destruction, we then have increased blood glucose, which is known as hyperglycemia. We also have another type of diabetes, which is type 2 diabetes. So type 2 diabetes is known as insulin resistance. So the body is still producing insulin, but the cell is not recognizing the insulin, and therefore insulin cannot do its job to take the glucose from the blood into the cell. Hence, we have a decreased insulin production from the pancreas. Now, common signs and symptoms of diabetes can vary a little bit depending on the type. These are the common ones. So we have polydipsia, which is increased thirst, polyuria, which is increased urination, and polyphagia, which is increased hunger. We also can have either an increase or decrease in weight, fatigue, blurred vision, slower wound healing, which makes us more susceptible to infection, and nausea. Now, these are just the common ones. Obviously, other signs and symptoms can be apparent. Type 1 is commonly diagnosed at an earlier age, and type 2 usually manifests at an older age due to lifestyle factors and choices. So, with the destruction and I guess non-functioning beta cells and not enough insulin, this can lead to the symptoms as previously discussed, as well as microvascular and macrovascular complications. So microvascular complications include neuropathy, nephropathy, and visual changes. Your macrovascular complications of diabetes can include heart disease, stroke, and peripheral vascular disease. When we have, I guess, too much blood glucose, this is called hyperglycemia. Now, there's two forms of hyperglycemic crisis. Now, these usually require urgent medical attention and treatment. So the first one is known as diabetic ketoacidosis, which has a rapid onset, usually within 24 hours. The patient will present generally with nausea, vomiting, and abdominal pain. This is due to the body not being able to use glucose as an energy source and fuel, so it then turns to fat cells. Now, when we use the fat cells, the breakdown of the fat cells produces ketone bodies, and that is what leads to the diabetic ketoacidosis. On the other hand, the second state of a hyperglycemic crisis is known as hyperglycemic hyperosmolar state. Now, this one here has a bit more of a gradual onset, so not as quick as the ketoacidosis. This can occur over days to weeks. Usually there's a decrease in weight, nausea, vomiting, abdominal pain, excessive thirst, excessive urination, headache, feelings of weakness and lethargic, and dizziness. So this osmolar hypoglycemic state also needs to be treated rapidly. We usually treat this one here with obviously fluids and the administration of insulin. So yeah, they're the two hypoglycemic crises. Diabetic ketoacidosis, more predominant in a type 1 diabetic, and then you've also got your hyperglycemic hyperosmolar state. Okay, so when we are initially diagnosing someone with diabetes, there's several things that we look for to confirm the diagnosis. We take their height and weight and calculate their corresponding BMI. We take their blood pressure. We do an abdominal exam, a fundoscopic exam, an oral exam of the oral cavity, a pulse evaluation, a skin exam to check for any infections and slow wound healing, a thyroid palpitation, cardiac exam, and a foot and neurological exam. How do we, manage diabetes? So the first thing we usually do, especially in type 2, is modify lifestyle factors. So this includes dietary modifications, educating on carbohydrates, what they are, how it affects the body and your sugars, and then also exercise to keep the body in a healthy weight range to reduce the incidence of microvascular complications and macrovascular complications. So someone with diabetes, we can actually manage this quite effectively to prevent those complications from developing. So we want to control their blood pressure. Our target for a diabetic patient would be a systolic blood pressure of 130 and a diastolic of 80. We also want to manage it, if we can't manage it with lifestyle modifications, such as what I mentioned before, and then we can go to pharmacotherapy. Pharmacotherapy is generally the last line option, especially in a type 2 diabetic. Type 1s are usually insulin dependent, so we usually see a lot of type 1 diabetics being administered insulin on various different regimes. There's several different forms of insulin. You've got your rapid acting, such as insulin lispro, aspart, and glulisine. You've got your short acting, which is your Humulin, and then your intermediate acting, which is your isophane or zinc derivatives, and your long acting, which is the insulin glargine and your Detamir. Excuse my pronunciation if I didn't do that correctly. So that is the management of type 1. Most type 1 diabetics will also make sure that they do their finger prick testing, and this will give them their range. Usually we like to see a random test between 3 to 6 millimoles, sort of depending on the individual and their risk for other complications. Now, if they're a type 2 diabetic, this usually develops later on in someone's life. So like I mentioned before, we want to manage the lifestyle risk factors. So smoking, alcohol intake, making sure their blood pressure is within range, making sure their BMI is within a good category. All those things come first. If the diabetes is still uncontrolled, we can introduce other agents. So the first line is metformin. The second line treatment is a sulfonylurea. And then your third lines are now, there's a lot of newer agents. So these are things like, you can get injections like Byetta, which is a daily injection, Bydureon, which is weekly. You can do Forxiga, which is a sodium glucose transport 2 inhibitor. There's glucagon-like 1 agonists now. There's incretin mimetics. There's so many newer agents that we can use. But traditionally we usually see metformin. If it's not stabilized with metformin and lifestyle modifications, the addition of a sulfonylurea is generally added. If that's still unmanaged, we can try some newer agents and some other medications that are available to us. Okay, so what lab tests do we have to do? So a HbA1c. This gives us an overview on how the patient's diabetes has been in the last sort of 3 months. So we want this level to be about a 7% or under. If it is over 7%, this indicates that we don't really have tight diabetic control and we need to review the treatment and the management. Now, we like to do the HbA1c blood test every 6 months. Annually, so once a year, we also do fasting lipids because high cholesterol can lead to cardiovascular complications. So most diabetics will see them on a statin drug, so a HMG-CoA reductase inhibitor, to keep their cholesterol levels within range. We will also annually do a retinal exam, so eye exam, and we will also test the microalbumin and the creatinine. Yeah, so a lot of diabetics will also have high blood pressure, so we need to address this. Usually, we will go for something like an ACE inhibitor or an angiotensin II receptor blocker. We might add a diuretic. We might use a beta blocker or a calcium channel blocker. It's very important to make sure that we keep the diabetic's blood pressure within that range of 130 over 80. So yeah, that was just a little quick outlook. I can also go over diagnostics of diabetes. So to diagnose it, we look at symptoms and random glucose. If their random glucose is over 200 milligrams per DL, that can indicate they're diabetic. Or if their HbA1c is over 6.5%, or a fasting glucose of 126. Or we can do a 2-hour glucose tolerance test where we administer 75 grams of glucose. If the level is over 200, that can also be a diagnostic tool. Now, increasing risk factors, if they have a fasting glucose between 100 to 125, the glucose tolerance test produces 140 to 199, or a HbA1c of 5.7 to 6.4. So all of these here are, I guess, tools that we use to diagnose diabetes. If someone is receiving the first diagnosis of diabetes, generally type 2 diabetes if they're a bit older, we will refer them directly to a diabetic educator and a dietitian and make sure they are looked after by an eye specialist and also a podiatrist. So that was my first video. It was a little bit shitty, but it's a work in progress. I also don't know how to do proper editing at the moment. But yeah, I guess you've got to start from somewhere. It was a little bit jumpy. I hope it was semi-easy to follow. It was very basic. It didn't go into too much detail, but I just want to keep it basic and straight to the point, and just for the first few, and then I will attack it with more in-depth explanations of pharmacology, how the drugs work, their mechanism of action, their side effects, and various things we need to look out for. I hope you enjoyed. Bye.